Hello everyone. The subject that I have chosen to discuss is infective endocarditis. The purpose of this study is to identify the main etiological factors of infective endocarditis. Endocarditis continues to remain one of the major problems of medicine due to increasing cases of infective endocarditis, the evolution of their etiology and clinic, widespread misuse of antibiotics, material and methodology that are used in this study are retrospectively. The informations are from 10 patients aged 14 to 80 years old that were hospitalized in the infections departments of Mother Teresa Hospital in a period of 6 months. But what is infective endocarditis? Infective endocarditis is a microbial infection of the endocardial surface of the heart, which affects cardiac valves, the mural endocardium, and septal defects. About gender distribution, we have seen that in our study is a predominance of the disease in men. This fact is also mentioned by some authors who refer that the average male to female ratio is 1.7 to 1, but in our data this ratio is more pronounced, 4 to 1. Regarding age distribution, in our study we have the 3rd and the 7th decade that are the most at risk. In this slide, we have the distribution by occupation, that the unemployed are 30%, the office employers are 20%, and the others are the same, 10%. To geographical distribution, we have the number of cases that is in cities 80% and in the village 20%. So is higher in cities than in the village. Here we see the classification according to infective endocarditis progress. So we have fulminant infective endocarditis, acute, that depends to several days to 6 weeks, subacute from 6 weeks to 3 months, and chronic infective endocarditis that is more than 3 months. In our study, we have seen that the risk factors are intravenous drug abusers, prosthetic valves, aortic stenosis, mitral stenosis, and the patients that are in dialysis. But we have more risk factors that can cause infective endocarditis. There are many microorganisms that can cause infective endocarditis. These are usually isolated in blood cultures. Bacteria is the most common cause, like Staphylococcus aureus, Streptococcus, Enterococcus, etc. Candida albicans can be one of them. The presence of 2 or more organisms combined with the older age of the patients is associated with a higher percentage of mortality. In this slide, we have the clinical manifestation. The clinical presentation of infective endocarditis is very variable. So in the next slide, we will have the manifestations that are in our study. Here are the symptoms that are shown in most of the patients that are temperature above 38 degrees, fatigue, cough, headache, increased sweating, especially at night, fever, myalgia, body ache, vomiting, chest pain, strong dyspnea, weight loss, anorexia, and dysphagia. Regarding to laboratory tests, we have essential test, that is blood culture, and routine test, hemogram. The hematological parameters are often altered in infective endocarditis, but none of the data is diagnostic. Urine is also altered. Erythrocyte demand and PCR are high. Complement levels are low. Rheumatoid factor is high. Biochemical balance is altered. And we have radiographic techniques that are very useful in diagnosis and chirurgical interventions. In the next slide, we will see the results of all the laboratory tests we have done in our study. As we mentioned above, the blood culture or hemoculture is the most important diagnostic test that we use in infective endocarditis. In our study, we have 60% of the results negative and 40% positive. In this slide, we see the result of positive blood cultures. In our study, the microorganisms that cause infective endocarditis are Staphylococcus aureus, Brucella, and Candida albicans. Here we have a graphic that demonstrates the size of vegetation and its respective percentage. In this slide, we have the vegetation topography with transthoracic echocardiogram. In this slide is shown that cardiac complications are higher than extracardiac ones. The main goals of therapy for infective endocarditis are the eradications of the microorganisms causing the thrombus and the preventions of complications from valvular infections, both intracardiac and extracardiac consequences. Bactericidal antibiotics must be used. Prolonged therapy is necessary, maybe weeks. Treatment is best started after multiple sets of blood cultures have been taken. Urgency of therapy is required for acute but not subacute endocarditis. Here are shown the results of treatment in the study, that 40% of the cases are improved. Only 10% are healed, and referred to surgical intervention are 30% and exitus are 20%. To summarize the results of the study, the number of patients diagnosed with infective endocarditis during a 6-month period was 10. The most affected age group was 31 to 40 years old. Men were the most affected in our study in a high ratio. 4 types of disease progression were observed, where acute infective endocarditis was predominant. From the blood cultures obtained, the most common etiological agent found was Candida albicans. Transthoracic echocardiogram showed the most affected tricuspid valve. Complications in our study reach up to 30%, regardless of the development of science. Mortality is 20%, so infective endocarditis remains one of the diseases with high morbidity and mortality. Whenever the art of medicine is loved, there is also a love of humanity. Thank you for your attention.